So in terms of funding, I receive funding from the United States National Institutes of Health, which is part of the Department of Health and Human Services, and I have no conflicts of interest. So the prevalence of diet and weight-related chronic diseases is very high, and in addition to disease burden and reduced quality of life, diet and weight-related chronic diseases are a substantial burden on the healthcare system. It's millions and millions and millions of dollars spent each year treating diabetes, cardiovascular disease, many cancers, which are largely preventable. And in addition to the reduced quality of life of the patients, there's reduced quality of life of the caregivers and the families, who then have a cycle of economic burden on them because the caregivers can't go to work because they're taking care of the people with the diet-related chronic diseases. So we simply cannot treat our way out of everything. I always say that my clinical colleagues are amazing. You know, we have amazing treatments for a lot of these chronic diseases, but we can't treat our way out of everything. It's too much quality of life, the healthcare system can't absorb it, and it's just too expensive. So prevention really is critical to the health of the nation. Now you've seen some slides that are very similar to this over the last couple of days, but basically this shows, starting in about 1935 up to about 2010, the most common causes of death in this country related to chronic diseases. And you can see that most of it is due to, let's see if I can get this right. Most of it's due to stroke, cancer, heart disease, and so forth right here. And even around the world, deaths from non-communicable diseases have increased markedly, and they're expected to rise. So you can see for both males and females, the non-communicable diseases, which are the ones we've been talking about for the last couple of days, are the ones that have the largest impact. So the rates of preventable chronic disease are too high, both in the US and around the world. The trajectories absolutely must be slowed, and prevention is critical. Nutrition is a cornerstone of prevention, and I might say it even is the cornerstone for prevention. So being the last speaker, I have the ability to be able to say that over the last couple of days, a summary that you've heard is that nutritional factors, and specifically consumption of a Mediterranean-style diet, is associated with reduced risk of cardiovascular disease, some cancers, cognitive decline, endothelial dysfunction, metabolic disorders, including diabetes, mortality, including CVD mortality, cancer mortality, and all-cause mortality, and weight gain. So how do we translate this to population recommendations? How do we take the research findings and translate to practical recommendations for the US population? I heard a term at lunch that I think we should all adopt. Over the last several years, the term farm to fork or farm to table has emerged. And the term I heard at lunch, which I really like, and I think we all should use, is science to table. You know, how do we get the science to the table, to the kitchen, and so forth? So science to table, that's about taking the research findings and translating it to practical recommendations for the US population and actually populations around the world. So one question to ask is, how did diet scores or dietary patterns and relative rankings of scores that you've seen presented in all of these cohort studies today and yesterday, all of those scores that are cited in research report, how does that relate to absolute intake of foods, food groups, and beverages? How do we take a score and advise on eating habits? Well, one of the first places to start is to examine the underlying metrics and measures used to assess diet and what they can tell us about a Mediterranean-style dietary pattern. And one thing that Melanie mentioned in my introduction was that I do a lot of work on methods. In fact, about a quarter of my research is on methodological work, and I really think that it's important to try to understand if what we think we're measuring is actually what we want to be measuring. So that's kind of at the heart of methods. So I want to spend a few minutes talking about that. Is what we're measuring really what we think we're measuring, and then how do we translate that science into recommendations? So in cohort studies, which is some of the large studies that Cindy and a number of others have presented throughout this conference, participants typically include a one-time baseline food frequency questionnaire. And this is a questionnaire where it's usually about 12 pages and might have anywhere from 80 to 120 line items, and people are supposed to mark on the questionnaire how often they ate that food. Was it every day? Was it less than once a month? Was it 3 times a week? And then the portion size, small, medium, and large. So they have to go through this questionnaire, really think about what they ate, and what they see on the questionnaire might be kind of close to what they ate. So then they have to think, well, was that what I ate, or did I eat something like that? Should I say yes or no? So when Cindy was mentioning measurement error with some of these, that's a little bit of what the measurement error is about. It might be similar to what someone ate, but not exactly. And so then the person filling out the questionnaire has to do a lot of mental gyrations about, well, this is sort of what I ate, but maybe not. Some subsets of these large cohort studies might also complete food records or 24-hour recalls, but because those methods of diet assessment are more time-consuming and take more staff time, they're typically more expensive than most of the large cohort studies of thousands and thousands of people, that it's really affordable. We also have population surveillance in this country. In 1990, our country passed the Nutrition Surveillance and Monitoring Act, which means that we have this National Health and Nutrition Examination Survey. We had it before 1990, but in 1990 it became a law. And I think it's great that we have a law that says that we have to do nutrition surveillance in this country. And so a lot of the big reports that you hear about that, people are eating about half their meals away from home, or all of the obesity maps that you've seen, a lot of that comes from our population surveillance. And that dietary assessment is done with single 24-hour recalls. It's a very detailed interview. The people who conduct these recalls are highly trained, and they ask the respondents, in person about everything they ate the prior day, midnight to midnight, including, cooking methods, oil added, including where they used olive oil or corn oil, brand names, and so forth and so on. So from a 24-hour recall, you can really get a lot more detailed data about any one individual's intake than you can from defined food categories on a food frequency questionnaire. But for all of these methods of dietary assessment, food frequency questionnaires, 24-hour recalls, and food records, the usual output that we look at as researchers is macronutrients and micronutrients. So protein, carbohydrate, fat, different types of fat, calories, all the vitamins and minerals, and so forth. And so here is just a screenshot of the food frequency questionnaire that we use at the Fred Hutchinson Cancer Research Center. And it's 12 pages long, has 122 of these line items. So when someone is filling this out, they have to think, okay, broccoli. Did I have broccoli in the last month or the last 3 months, whatever the time range is that they're asked to complete it in? And then they have to think about the portion size. Most people are kind of bad at thinking about a portion size or how much they ate. So in reference to 3/4 of a cup, they have to think, well, do I usually have more than that, less than that, about that much? Same with a lot of these other, vegetables, and, it goes on to a lot of the other major food categories. So to assess the Mediterranean diet with standard U.S. dietary assessment tools, food frequency questionnaires, 24-hour recalls, and food records, we really need some new approaches to assess a dietary pattern, because as I showed on a slide a moment ago, the standard output is the nutrients. We can get about 140 nutrients out of these assessment methods. So instead of getting the nutrient output, we use these scoring systems to assess diet quality or diet patterns. And I've shown 3 here that you're probably familiar with and you've heard about in some of the other talks in the conference: the Healthy Eating Index, the Alternative Healthy Eating Index, and the Alternative Mediterranean Diet Score. And I've highlighted that one because that's the one I'll spend the most time on. So what happens with these scoring indexes is that we call them a priori scoring systems. So we don't use statistics to try to see where foods sort out, but we have these a priori investigator-defined categories that kind of group foods together, and they give points based on the responses to the FFQ line items. So I showed the line items a few slides ago for just one page of the FFQ. So these scoring systems characterize the whole diet rather than just focusing on a few nutrients. And one of the things that I like to think about, not just with the Mediterranean diet, but with diet as a whole, is that the whole is more than the sum of its parts. And I think Cheryl Lynn mentioned at lunch that we have these food components that Americans like to focus on, that about every 5 or 10 years someone talks about a superfood, and then that's all the rage. And then there are these so-called evil foods that the public comes up with as being evil, and right now half the world thinks that gluten is bad, even though they don't know what it was. But the last decade it was high fructose corn syrup. And that's a very, what I would call, reductionist approach to thinking about diet, that those of you who work with patients probably know that people like to focus on these small things. But really, the whole is more than the sum of its parts. And I think that's a lot of what the Mediterranean diet is about, too. It's not just olive oil, it's not just legumes, but really, the whole is more than the sum of its parts. To really understand the benefits of Mediterranean-style diets, or the components in a Mediterranean-style diet, we really need standardized approaches. And so probably about 3 years ago, a group of scientists from NCI, University of Hawaii, myself at the Fred Hutchinson Cancer Research Center, and the University of South Carolina, we got together to talk about this, that we really want to be able to understand dietary patterns across all of the cohorts that we worked with, including the Mediterranean diet, but we really felt like we needed standardized approaches, and then we wanted a way to be able to translate it to actual recommendations to the population and to individuals. Because when we reviewed the literature, we found that there was so much inconsistency, not just in how the scores were derived or applied, but also in how statistical models were made. So some studies would adjust for BMI, or weight, and others didn't. So then it's really hard to compare, apples to oranges or olive oil to peanut oil, when everybody is using a different approach. So we called ourselves the Dietary Patterns Methods Project, and I'll spend a few slides telling you about some of the work that we've done. We have 3 cohorts involved in this project: the NIH AARP Diet and Health Study, which is based at the National Cancer Institute, the Women's Health Initiative, which Cindy told you a little bit about earlier today, and that's coordinated at the Fred Hutchinson Cancer Research Center, where I'm located, but we also have had 40 sites throughout the U.S., including here in Arizona at Tucson and Phoenix, as Cindy mentioned. And then the third one is a multi-ethnic cohort, which is based at USC in Los Angeles and at the University of Hawaii. And we were really interested to see how some of these scoring systems that have been developed to assess dietary patterns would perform across the cohort. So we were interested in the DASH eating plan, the Mediterranean diet, the Healthy Eating Index, and the Alternative Healthy Eating Index. So all 4 of those, we were interested in how they performed and what we could take home and then tell the public. One of the things that we really wanted to do was have standardized methods. So we met, rigorously by conference call every week for a year. We had a couple of in-person meetings, and we reviewed and discussed each one of these diet quality indices, including the Mediterranean Diet Score. We developed SAS code for scoring each index, so all of the analyses used identical ways to define the dietary patterns, including the Mediterranean score. We had a lot of discussions about that because not every FFQ across all of those studies was equal, because each study has developed its own. So we had to come to a lot of decisions about how to rank certain things. So for instance, nuts. We've talked a lot about nuts being part of the Mediterranean diet pattern. Well, what do you do when one of those FFQs doesn't even have a line item for nuts, and then another one just has nuts grouped with something else like peanut butter? So we had a lot of discussions about, okay, how are we really going to create this score? We can't really make a silk purse out of a sow's ear, but we have to try to, really have rigorous methods as far as possible so that we're all measuring the same thing, defining it equally, and so forth. So we also identified standardized approaches for exclusions. So when to exclude a questionnaire from someone if they hadn't filled it out completely, or what really was acceptable, not acceptable. We did have some cohort-specific exclusions. Some of the other specific ones that we exclude, at least for our initial analyses, is if someone had a history of CVD or cancer when they entered the cohort. We excluded them because we were interested in, the follow-up, like if they report a certain dietary pattern at baseline entry, we wanted to know the incident or first-time occurrence. So we didn't want to muddy that up with people who'd already been diagnosed. We also examined covariates and potential other risk factors, which of course varied across the cohorts as well, and that made it very challenging. So some of these cohorts, if you read them, I'll just give you an example of some of the covariates that we dealt with and really wrestled to come up with standardized approaches. Body mass index. So in the Women's Health Initiative, all the participants came to a clinic visit, so we had measured height and weight using a standardized protocol, and we have both continuous BMI available as well as categorical cut points for normal weight, overweight, and obese. So we had a variety of things available. In contrast, the NIH AARP study was all done by self-report. It was mailed questionnaires. So it was self-reported height and weight from which BMI was computed. So we had to wrestle with, well, one self-report, one is, measured. They're different. We have to deal with it. And here's a more comprehensive list of some of the things that we, wrestled with and had to decide, what to do across both of them. Oops. Sorry. Age, ethnicity, education, smoking, physical activity, because of course all 3 cohorts measured physical activity differently. Marital status, I'll get to the alcohol in a few minutes, and also postmenopausal hormone therapy. WHI had pages and pages of history of postmenopausal hormone use because that was one of their major research questions, whereas, say, the MEC multi-ethnic cohort study, they might have had 1 or 2 questions. Did you ever use postmenopausal hormone therapy? Are you using it now? Whereas WHI had very detailed data. So we had to deal with all that. We applied our statistical analyses consistently across the 3 cohorts. We shared the code. We had a lot of meetings about making sure everything was consistent. And then there were a few cohort-specific questions. So we initially talked about, okay, how are we going to measure the Mediterranean dietary pattern? Are we going to use the Tricopolu approach? And you've heard about this, the high monounsaturated saturated fat ratio, the high consumption of fruits, moderate alcohol, high consumption of legumes, cereals, breads, and potatoes, and vegetables. Or the other alternative was to use the alternative Mediterranean diet score developed by Teresa Fung, which is very similar to the Tricopolu. It has these 8 components, and then what they call a detrimental component for red and processed meats, and you get a score between 0 and 9, where a low score, 0, 1, or 2, means that you don't eat very many of these. The mid-range means you eat it some of the time, and high range means you eat all those and not much red and processed meat. Ultimately, we decided to go with this scoring to be more comparable with most of the other cohort studies that we're publishing, up to this time. So most of the studies that you'll see, published are using Teresa Fung's AMED score. So that was why we decided to use this one. So with this AMED scoring, as I mentioned, there are 9 points total. And again, you have to use the food frequency questionnaire in a little bit different way because we're not using the nutrient output. You have to go back to what we call the unprocessed data, where you just have the raw data of where people, responded, that they, ate certain fruits, vegetables, cereals, and so on, and manipulate it in a different way. And once you have all of that, 1 point is given if someone's intake is above the cohort-specific median for vegetables, legumes, fruits, nuts, whole grain cereals, fish, monounsaturated fat, saturated fat ratio. So you get 1 point for each of those, and you have to be able to compute the median values across the entire cohort. Split it down the middle, and you get a point if you get above the cohort median. You don't get a point if you're below the cohort median. 1 point was also given if someone's intake is below the cohort-specific median for red and processed meat. So again, you have to go through all the line items, figure out how much people are, bubbling in those amounts, once a week, never, every day, so forth. Figure out what the median is. And so it's not a small amount of work to do, when there's 80, 90,000 people in a study. And you get 1 point if your intake is below the median, compared to everybody else in the cohort. You don't get a point if you're above the median. Additionally, the AMED gives 1 point for alcohol. So for men who drink between 10 and 25 grams a day, they get a point. And for women, it's between 5 and 15 grams of alcohol a day. And it's very important to note that median intakes vary across cohorts. So the median intake for the Women's Health Initiative for all of these things is going to be different than the AARP study, which is going to be different than the MEC. So that's just something to keep in mind when thinking about this AMED score, is it's based on if someone is above or below the median intake for all of these components of the diet. Okay, so this is a set of some of our publications that we have so far. The first 3 are the cohort-specific results from the AARP, the Women's Health Initiative, and the Multi-Ethnic Cohort Study. And then the last paper, which was just published a few weeks ago, is what we call a synthesis paper, where we talk a little bit more about some of these methods that I'm presenting now. So the figures I'm going to show on this slide are in the Lise paper that was just published in the Journal of Nutrition. And one of the things that we found was that there was remarkable consistency across these cohorts and across the diet scores. So as I mentioned, we were interested in the Healthy Eating Index, the Alternative Healthy Eating Index, the Alternative Mediterranean score, and the DASH. And let me just walk you through this. You can see all those up at the top. The AMED score is the symbol that has the triangle. The cohorts are at the bottom. So right here, if you look up, this is the AARP women, the MEC women, the Women's Health Initiative, and it's only women, of course, the AARP men, and the MEC men. So let's focus on the triangles because that's the AMED, or the Mediterranean Diet Score. So for AARP women, this score right here suggests that women who had a higher score or close to 9, somewhere in the neighborhood of 8 or 9 points on the alternative Mediterranean diet score, they had about a 20% reduced risk of CVD mortality. And you can see that that is very similar across all of these cohorts. So same for the MEC women. Theirs was a little bit higher, maybe about a 18% reduced risk of CVD mortality for having a good score compared to a bad score on the AMED. For the Women's Health Initiative women, same thing. Theirs was actually a little bit better than the AARP. Theirs was maybe about a 22% reduced risk of CVD mortality for having a good AMED score versus bad score, and so forth. Because these triangles, all line up very similar, somewhere in the range of, 18 to 25% reduced risk of CVD mortality, that was pretty remarkable to us, that across these big cohorts, we could find a very similar, what we call effect size. So in general, between 18 and 25% reduced risk. So that's really quite meaningful because I don't know how well pharmacological agents do at reducing CVD mortality. But if you can imagine everyone adopting a healthy diet like this and having it reduce CVD mortality by 20, 25%, that's really very remarkable. Similarly, for cancer mortality, we have wider confidence intervals for cancer mortality, so that means that we have less certainty in the estimate, but still we did see reduced risk for cancer mortality when you look at all the triangles. Again, it's around a 15, 20, 25% reduced risk of cancer mortality. And then for all-cause mortality, the AMED score continues to do very well. So we were, very pleased, but somewhat surprised at the consistency. And usually we say in observational studies, we need to have consistency. That one study is never enough. In population-based studies, we can never say, oh, eureka, I found it, we've got it, this is it. We need to have consistency and have things repeated across a lot of cohorts. And what's additionally interesting about these 3 particular cohorts, which I think can give us a good lesson, is that they were very different. The AARP study was a nationwide study of retired persons, so men and women. The Women's Health Initiative was only postmenopausal women, so that's different. And the multi-ethnic cohort study, from its name you can imagine they have a lot of minorities. So a high proportion of Native Hawaiians, African Americans, and Hispanics. And we really have very little good data on a lot of ethnic minorities and dietary patterns and reduced risk. But here this study shows that even in the MEC, these healthy dietary patterns are reducing risk for disease mortality, which we thought was remarkable. So as I mentioned, there was very marked consistency in the hazard ratio values across the cohorts. So for all-cause mortality, there was about a 26% reduced risk, and it was pretty similar for men and women. Same for CVD mortality, reduced risk, and for cancer. So that was pretty amazing. So the next thing we wanted to do, and I'm going to take a few minutes to walk you through this slide, because one of our goals was to try to understand, okay, now what do we tell people to eat? We don't want to tell people to adhere to a score. We want to be able to tell people what to eat. So we looked at all of the scores, the HEI, the AHEI, the AMED, and the DASH, and we looked at the types of foods that are included or not included in those scoring systems. So that's what you see in this left-hand component. These are the components in each one of these scoring systems that are used to give points or take away points for these diet components. So for the AMED, you get 9 points total. You get points for vegetables, fruit, nuts, legumes, fish, whole grains, oils and fats, alcohol. And you don't really get negative points for the red and processed meat, but you can only get a point if you have a lower amount relative to everybody else in your cohort. If you look across these, you'll see that the scoring systems are quite different. So for the HEI, the total scoring points available is 100. For the AHEI, it's 110, and for the DASH, it's between 18 and 40. And there are some characteristics of some of these other scoring systems that are not found in the AMED. So for instance, in the HEI, you get negative points for having refined grains. You get negative points for empty calories, which is basically added sugars. They don't do anything with sugar-sweetened beverages, whereas the AHEI and the DASH give negative points for sugar-sweetened beverages, and then the AMED is the only one that doesn't give negative points for sodium, where the others do. So you can see that there are some differences across these, and one notable feature about the AMED is that only the HEI and the AMED give points for fish, and they are also the AHEI and the AMED only give points for alcohol. So there are some differences across these, but we want to try to get a handle on, okay, what really are the foods? Let's try to break it down. And we did find that the common underlying constructs across these scores were whole grains, vegetables, fruit, plant proteins. So similar to what you've heard the last couple of days, but again, how much should be consumed? What do we tell people? What can we offer for dietary guidance, and where does the benefit begin? Do you have to eat legumes every day? Do you have to eat, a whole cup of legumes? Can you eat half a cup? Where is the benefit? So one thing that we noticed when we did our analysis and looked at all the results is that for all-cause mortality, diet intake levels as low as the second quartile were associated with a reduced risk. The best benefit was if you were in the top quintile, Q5. These are the people that have the best scores, close to 9. But even people who were doing some adherence, adopting some of it, had some benefit. And for CVD mortality, they had to do a little bit better. They had to be at least in the third quintile for reduced cardiovascular disease for men, and the second quartile for women. And then for cancer, it was also pretty similar. So what this slide is an attempt to kind of show you some amounts. Where does the benefit begin? So what we did was we took those common elements, and these are all things that were common across the indices but include the AMED, and we looked at them in terms of amounts per 1,000 calories. So for whole grains, these are ounce equivalents per 1,000 calories. For fruit, it's cup equivalents per 1,000 calories. For low-fat dairy, cup equivalents per 1,000 calories. For alcohol, it's grams per 1,000 calories. Total fat, grams per 1,000 calories. And fiber, grams per 1,000 calories. And when you think about the current food labels that are based on a 2,000 calorie diet, you can think about sort of doubling these amounts to get that. So in quintile 5, where we saw the best benefit, those whole grain ounce equivalents per 1,000 calories were between 0.6 and 1.4. And the reason it varies a little bit is that it varied across cohorts. So that's why we show the range here, because this includes all 3 of the cohorts, the AARP, the WHI, and the MEC. So between 0.6 and 1.4 ounce equivalents per 1,000 calories per day was the amount on the Mediterranean diet score that was associated with benefit. In quintile 2, where we start to see some benefit, it's better than nothing, it was a little bit lower, 0.4 to 0.6, and so on for all the dietary elements. So that was a way, was a way for us to kind of get a handle on, okay, if someone asks, how much vegetables I should eat a day, is it 5 a day, is it 9 a day, what is it? Well, with this diet scoring, the best benefit was 1.2 to 1.6 cup equivalents per 1,000 calories, or on average, if someone's having 2,000 calories, double that amount. That was the amount that was beneficial. So given that the benefit of higher dietary quality seemed to start at around Q2 to Q3 for total mortality, even small improvements at a population level could be meaningful. So those of you who work with patients, if someone is not quite ready yet to take the full plunge, they can make some small improvements and it'll help. And it will certainly help on a population level. So that was one of the take-homes that we had, is that not everyone will need to change everything at once, but any small improvement in diet can help. If they can get in, one more vegetable serving a day, substitute a refined grain for a whole grain, any little inching that you can do to get up to close to what would be like a 9-point score is great. So I want to talk for just a minute about some of the unique components to the AMED score, and Cindy touched on this a little bit this morning, and that's alcohol. So as you saw a few slides ago, the only diet scoring index that gives points for consuming alcohol is the Alternative Healthy Eating Index and the Alternative Mediterranean Diet Score. Oops. So the AMED awards points for alcohol consumption, and you get 1 point if you have between 5 and 15 grams a day if you're a woman, and 10 to 25 grams a day for a man. Well, what does that mean? It's a glass of wine. A glass of wine has 12 grams of alcohol. 1 bottle or can of beer has 13 to 14 grams of alcohol, and 1 shot of liquor or spirits has about 14 grams of alcohol. So it's really a relatively low amount. If someone is on the low end, 5 grams, that's not much, or you might think of it as an every other day kind of consumption. And yet, as Cindy mentioned this morning, the WCRF-AICR report on diet and cancer, which was also mentioned in the first presentation this morning, and this is a large review of a lot of literature, shows that for premenopausal breast cancer, and this was a 2010 report, showed that alcoholic drinks, that there was convincing evidence that alcohol increases premenopausal breast cancer risk. And similarly, for postmenopausal breast cancer risk, this report concluded that there was convincing evidence that alcoholic drinks increase risk of postmenopausal breast cancer. And then for cancers of the colon and rectum, there was convincing evidence that alcoholic drinks increase risk for men, and probable evidence that alcoholic drinks increase colon and rectal cancer risk for women. In addition, some things to think about are that many mixed drinks, cocktails, also contain added sugars and other non-healthful dietary components. So it doesn't necessarily have to be straight added sugar, but maybe, a mix that's made with, a lot of sodium or, artificial flavors and colors and, some of those syrupy things that are put in alcoholic drinks. So I think my main point is that more research is needed to identify what are the healthful aspects of alcohol in the Mediterranean diet. Because the way that these scores are used now in the research world is that the point is awarded for any type of alcohol. It doesn't matter what kind it is. It doesn't matter if it's red wine, white wine, beer, alcohol, a cocktail that has a lot of added sugar. And we have to keep in mind that we do have this large body of evidence showing that alcohol is associated with increased risk of both premenopausal and postmenopausal breast cancer risk and colon and rectum cancer. So we can't really ignore that body of literature. We need to figure out how to deal with it. Is there something else that we can tease out so that we can advise patients correctly? And for those of you who work with patients, I'm sure you get this question a lot, especially if someone is a breast cancer survivor or a colorectal cancer survivor. That's probably going to be one of their first questions. Can I drink? How much should I drink? And so forth. So this is something that we really need to understand better. Other research needs relative to guidance. How about vegetables? The AMED score treats all vegetables as equal. But we know from, botany that they're not. A lot of the botanical properties of the Brassica family are different than, say the Solanaceae family, which includes, tomatoes and potatoes and so forth. And we probably need a variety of all those things to get the best intake. But we need to understand better if there's specific vegetables that provide more benefit. Similarly, someone mentioned the fruit we had at breakfast, and it was beautiful. I just loved that fruit we had for breakfast. I'm such a fruit fan, I just can't get enough of it. The AMED score treats all fruits as equal. Are there some that might have more benefit than others? And this is where we can, cross-partner with our colleagues, you're in a school of ag here, in botany and plant science and so forth to try to better understand, the actual botanical properties and health properties of some of our wonderful produce. Another question is how similar or different are the U.S. vegetables and fruit compared to Mediterranean vegetables and fruit? One of the compounds that no one has mentioned yet, unless I missed it, was flavonoids. Flavonoids are just a really very, very interesting compound present in mostly in fruit. And an interesting thing that I've learned about them is that when the fruit is stressed, so under high heat conditions or something like that, they make more flavonoids. And there's some thought that that might be one of the beneficial components in red and purple grapes that then get made into wine. But the growing conditions in the Mediterranean, may be different from a lot of the United States, even though it was noted in one of the presentations that the climate in Arizona is similar to the Mediterranean. There's a lot of other places where we get our food because we have, global shipping and transcontinental shipping of our food. So we need to better understand, how different or similar the produce is that's grown and sold here. How does shipping, long distances affect some of the nutrients and so forth? How about nuts? I mentioned nuts earlier. Many FFQs don't have a single line item for nuts. And, nuts are great source of protein, great source of some of the polyunsaturated fatty acids, but not all nuts are created equal. They have a really different profile of fatty acids. So when you're telling someone, okay, eat nuts, that's part of the Mediterranean diet, what kind of nuts are you going to tell them? You're going to tell them just almonds and walnuts? What if they don't like those? What if it's too expensive? Is it okay if they eat macadamia nuts? Well, those have a pretty different fatty acid profile, so what are you going to tell them? So we need to understand that better. Is it a certain type of nut in the Mediterranean diet? Should they only eat that, or can it be expanded? So we really need research on that. Same with the legumes. A lot of the legumes in the Mediterranean diet are, the garbanzo beans made into hummus, cannellini beans, some of the white beans. Well, a lot of people in the U.S. eat, kidney beans and red beans and so forth. Are those the same? Do they have the same properties? We don't really have enough research that I know of to really compare those, but we need that so we can better advise people. We don't want to tell people, oh, well, this is how you should eat, when we don't really have the research to back it up. So additional research is needed to better identify and characterize some of the specific foods consumed. And remember that FFQs only provide categories of similar foods. They don't really capture what someone actually ate. They characterize something that might be similar to what someone ate. And in our Dietary Patterns Methods project that I mentioned to you, one of the things that we hope to do over the next year or two is to expand our research by examining the specific foods in the cohorts, the 3 cohorts, the AARP, the Women's Health Initiative, and the MEC, with the specific foods consumed, because those 3, at least 2 of them, have diet record and 24-hour recall data. So what we're hoping to do is to take the food record and the recall data and really try to extract out the specific foods that people ate, food preparation methods, oil use, and so forth, and then categorize them also into the AMED and other scores. And I think we might get a really good handle on some more specifics compared to the FFQ. So in summary, a Mediterranean-style diet reduces risk of CVD mortality, cancer mortality, and total mortality in the 3 diverse U.S. cohorts when similar methods and metrics are used. And I noted that the effect sizes for risk reduction were remarkably similar and have the potential to have a very large public health impact. The components of a Mediterranean-style diet are whole grains, legumes, fruits, vegetables, nuts, legumes, fish, and certain oils and alcohol. Some characteristics of the U.S. diet that are not included in the scoring include added sugars and refined grains, and unfortunately these are consumed at way too high of a level in the U.S. diet, so they become sort of a 0 when you apply the AMED scoring system because they're not included. So we need to have a better handle on how to include and sort of subtract points off some of those negative aspects of the typical U.S. diet. And we also need research to identify specific foods in the U.S. food supply, fruits and vegetables especially, that confer the most benefit. So I'd like to acknowledge my colleagues at the Dietary Patterns Methods Project. They're listed here, the Women's Health Initiative, and also the Fred Hutchinson Cancer Research Center Nutrition Assessment Shared Resource. So thank you very much.